Nursing care and interventions in clients with pituitary/adrenal gland disorders. Keith Risher RN, MA, Ken. Today's objectives. Compare and contrast pathophysiology and manifestations of pituitary/adrenal gland dysfunction. Identify nursing priorities and client education associated with pituitary/adrenal gland dysfunction. Interpret abnormal laboratory test indicators of pituitary/adrenal gland dysfunction. Analyze assessment to determine nursing diagnoses and formulate a plan of care for clients with pituitary and adrenal gland dysfunction. Describe the mechanism of action, side effects and nursing interventions of pharmacological management with pituitary and adrenal gland dysfunction. Patho, endocrine system. Endocrine glands. Pituitary glands. Adrenal glands. Thyroid glands. Islet cells of pancreas. Parathyroid glands. Gonads. Hormones. Negative feedback mechanism. Endocrine glands secrete hormones. Hormones are natural chemicals that exert effects on target organs through transport in the blood. Includes pituitary, adrenal, thyroid, islet cells of pancreas, parathyroid glands and gonads. Works with nervous system to regulate overall body function and maintain homeostasis, keeping body temp glucose in normal range. Hormones recognize target tissues and bind to receptor sites on target tissue through a lock and key receptivity. Negative feedback mech. Hormone secretion dependent on need of body for final action of hormone. The secretion of that hormone causes the opposite action. Example: insulin and blood glucose. Patho, pituitary gland. Anterior growth hormone. Thyroid stimulating hormone, TSH. Adrenocorticotropic hormone, ACTH. Follicle stimulating hormone, FSH. Luteinizing hormone, LH. Posterior vasopressin. Antidiuretic hormone, ADH. Alterations of one or more hormone results in metabolic problems and sexual dysfunction. Growth hormone stimulates the liver to produce substances known as somatomedins that enhance growth activity. Growth hormone. Bones and soft tissues promote growth. Thyroid stimulating hormone, TSH. Thyroid stimulates synthesis and release of thyroid hormone. Adrenocorticotropic hormone, ACTH. Adrenal cortex stimulates synthesis and release of corticosteroids. Follicle stimulating hormone, FSH. Luteinizing hormone, LH. Both ovary or testes, men testosterone and sperm production. Women ovulation and estrogen secretion. Posterior vasopressin. Antidiuretic hormone, ADH, kidney, promotes water reabsorption. Anterior hypopituitarism. Causes: tumor, brain or pituitary, anorexia, shock, growth hormone, gonadotropins. Women, men. TSH. ACTH. Usually it is one hormone, not global. Deficiencies in ACTH. TSH most life-threatening due to corresponding decline in adrenal and thyroid glands. Growth hormone. DIC. Bone density, muscle strength. Gonadotropins. Women. Amenorrhea, anovulation, low estrogen, breast atrophy. Men. Decrofacial hair, decrolibido, impotence, reduced muscle mass. TSH. Thyroid levels, weight gain, alopecia, lethargy. ACTH. Cortisol levels, lethargy, anorexia, hypoglycemia, hyponatremia. Anterior hypopituitarism. Labs: T3, T4. Testosterone, estradiol levels. Nursing interventions. Replacement of deficient hormones. Androgen therapy. Gynecomastia can occur. Estrogens and progesterone. Growth hormone. Assess function of target organ. Thyroid. Labs. Easier to measure the effects of the hormones rather than their actual levels. Anterior hyperpituitarism. Causes. Pituitary tumors or hyperplasia. Gigantism. Acromegaly. Hormone most commonly involved is growth hormone. Gigantism is the onset of growth hormone hypersecretion before puberty. Acromegaly is the onset of growth hormone hypersecretion after puberty. Hyperphysectomy post-op care closely monitor neuros. Assess for postnasal drip halo sign. Avoid coughing early after the surgery. Keep HOP elevated. Assess for meningitis. Replace hormones and glucocorticoids as needed. Diabetes insipidus. Assess I&O closely first 24 hours. Hypophysectomy, surgical removal of the pituitary gland, most common treatment for hyperpituitary. Incision made in upper lip and access pit. Gland through the sphenoid sinus, nasal pact. Posterior pituitary gland, diabetes insipidus. Patho. Antidiuretic hormone. Deficiency. Water unable to be reabsorbed. Water metabolism problem caused by an antidiuretic hormone deficiency. Water is excreted as urine instead of being reabsorbed. Polyuria and dehydration. Diabetes insipidus is classified as nephrogenic, inherited. Primary, deficit in hypothalamus or pituitary. Secondary, trauma, tumors. Drug-related, lithium, diclomycin. Diabetes insipidus, clinical manifestations. CV. Tachycardia. Hypotension. Hem concentration. Renal. Dramatic increased UO. Skin. Dry mucous membranes. Neuro. Thirst. Irritable. Lethargy to unresponsive, diabetes insipidus, interventions. Nursing diagnostic statements. Deficient fluid volume R/T. Decreased cardiac output R/T. Priorities. Early detection dehydration. Maintain adequate hydration. Desmopressin acetate, DIP, intranasally. Synthetic vasopressin. I&O daily weights, syndrome of inappropriate antidiuretic hormone secretion, SIAD. Patho. Vasopressin, ADH. Increased. Water retained. Dilutional hyponatremia. Causes. Cancer. Infection. Chemo agents. COPD. Patho. ADH secreted even though serum osmolality normal, common complication with some cancers. Water is retained which results in dilutional hyponatremia. Cancer. Small cell lung CA, pancreatic CA, Hodgkin's non-Hodgkin's lymphomas. See clinical manifestations. Fluid retention. Hyponatremia. Neuro. Lethargy. Ha. Altered log. CV. Tachycardia. Renal. UO decrease. Neuro SX when now decreased below 115. C. Nursing interventions. Nursing diagnostic priorities. Decreased cardiac output R/T. Fatigue. Fluid restriction. Drug therapy. Dietetics. Hypertonic saline, 3%. Neurologic assessment. Orientation. Safe environment. Input of 500 cc water. Adrenal glands patho aldosterone cortisol catecholamines. Epinephrine. Beta receptors. Norepinephrine. Alpha receptors. Deduced aldosterone levels. Hyperkalemia. Acidosis. hyponatremia, hypovolemia, patho. On top of each kidney. Aldosterone. Maintains extracellular fluid volume. Promotes sodium and water reabsorption and K excretion. Regulated by renin-angiotensin system. Cortisol. Influences CHO, fat and protein metabolism. Body response to stress. Immune function. Must be present for other important processes to occur. Adrenal glands, hyperfunction. Acute adrenal insufficiency. Addisonian crisis. Causes. Steroids stopped abruptly. Clinical manifestations. Muscle weakness, fatigue, constipation. Hypoglycemia. Diaphoresis, tachy, tremors. Blood volume depletion. Hypokalemia. Cardiac arrest rhythm changes. Causes most common steroid therapy stopped suddenly. Steroids depress natural production and must be tapered to allow pituitary production of ACTH and activation of adrenal cells to produce cortisol. Life-threatening event in which need for cortisol and aldosterone is greater than available supply. Occurs as result of stressful event, surgery, trauma, infection. Most common causes. Addison's disease, interventions. Promote fluid balance and monitor for fluid deficit. Careful I&O. Record weight daily. Assess vital signs every 1 to 4 hours. Assess for dysrhythmias or postural hypotension. Monitor laboratory values. NR. K. Glucose. Cortisol and aldosterone replacement therapy. Diet, sodium, potassium, carbs. S&P. Adrenal gland, hyperfunction. Patho. Pheochromocytoma. Cushing's syndrome. Causes. Primary/secondary malignancies. Steroids. Lymphocytes. Inflammatory/immune response. Pheochromocytoma. Catecholamine-producing tumors that arise in chromaffin cells. Intermittent episodes of hypertension or attacks varying in length from a few minutes to several hours. Main treatment, surgery. Cushing's. Excess stimulation of ACTH, adrenal hyperplasia resulting in adrenals being less responsive to gonadotropin. Cushing's disease, clinical manifestations. Obesity. Changes in fat distribution. Moon face. Facial hair for women. Thin skin. Blood vessels fragile. Acne. Immunosuppression. HTN. Water/sodium retention. Lab changes. Glucose. WBC. Sodium. Potassium. Lab changes. Glucose inc. WBC dec. Sodium inc. Potassium dec. Nursing priorities: excess fluid volume R/T. Risk for infection R/T. Deficient knowledge: medical management, drug therapy, radiation therapy might attain. If caused by side effect of medication, try to decrease or change meds. Radiation therapy. Pituitary tumors. Drug therapy. Mitotaine. Adrenal cytotoxic agent used for inoperable adrenal tumors to decrease cortisol secretion.